Welcome back to the Barbell Medicine Podcast, where we bring modern medicine to strength and conditioning and strength and conditioning to modern medicine. I'm your host, Dr. Jordan Feigenbaum, and this is an episode of The Rundown, where we cut through the noise and give you the latest headlines in medicine, fitness, nutrition, and sports. I'm joined by the second most handsome doctor in North America, Dr. Austin Baraki, and we've got a packed agenda today covering everything from a purported creatine overdose, which might be the first on record, to the latest on blood pressure, LeBron James doing silly stuff in the gym, and the rise of new technologies. So, Dr. Baraki, unless you have any announcements, let's get
No announcements. Let's do it.
All right, we're doing it. So this first one, I saw this. I only watch a handful of sports, and one of them happens to be golf. I know that people are like, why do you watch golf? Because it's the most boring sport to watch ever. That is only true if you don't play golf. Anyway, I saw this interview happen live, and I was like, we have to talk about this. This guy, Ben Griffin, has had a breakout season. He'd been kind of a journeyman golfer, professional golfer most of his career, and now he's won multiple times on the tour. He's on the Ryder Cup team, which happened, depending on when this comes out, recently. In any case, he, in one of the playoff rounds, he had like a terrible stretch of holes. He began with a triple bogey, which is bad if you don't play golf. That's not good. Followed by a double bogey, which is also bad, but less bad than the triple bogey, and then a bogey, which is also bad, but again less bad than the triple and the double. So he's 6 over through the first 3 holes, which is objectively terrible. And he attributes this poor performance to swallowing a large amount of creatine in his shake after he teed off. He called it a rock of creatine, which it's the first time I've ever seen that combined together. He said he was super shaky. He experienced tremors, and he attributed that to his inability to perform on the course. Subsequently, his caddy helped him drink water and calm down, apparently. And he turned his performance around and ended up shooting a 69, which is under par. So he finished 12th in the tournament. And in his post-round interview, he was like, it was the creatine. I think I overdosed on creatine. So, Dr. Baraki, in your professional medical opinion, despite not being a board-certified toxicologist, what is the likelihood here of a creatine overdose?
Not a board-certified toxicologist, but an amateur toxicology nerd. And so I suspect that the likelihood of creatine overdose here is quite low for a lot of reasons. Knowing what we know about creatine itself, its mechanism of action, how long it takes to quote-unquote work and have its effect, how long that effect will tend to last. None of those things fit with this syndrome that was described here. So a lot of times when you're evaluating somebody with concerns for some sort of toxic ingestion, we look for particular what we'll call syndromes that might lead you in the direction of what might be the mechanism of how this drug or ingestion is impacting the person's physiology. So is it something that's like activating their sympathetic nervous system, or is it, blocking some other pathway? And we can see certain signs either on an exam or with labs or based on the symptoms the person's having, or are they having seizures? What do their pupils look like? What does their EKG look like? So there's a ton of things that we can use to assess this. And he describes apparently in relatively short order after this ingestion, which is worth noting, faster than creatine tends to have any physiologic effect, feeling super shaky, tremors. And so that's kind of like this more activated state, which is also not something that creatine causes physiologically, like a sympathetic or like a caffeine or something else that is more stimulant in nature might tend to lead to. So that also doesn't fit. And then finally, we know, for example, once somebody does take some creatine, say they've been taking it consistently over time, how long does it take to wash out of your system? It takes on the order of a couple weeks to start washing out of your system, right? And so not only does the timing in terms of ingestion to symptoms not make a ton of sense, the symptoms themselves don't make a ton of sense. And then the fact that within the same round, he's able to drink some water and just chill out and then return to his prior level of really strong performance. That timeline of recovery also does not make sense for the substance that is purportedly ingested. And so, it's not to say he didn't experience something. He obviously did, but attributing it to creatine in general or a quote unquote overdose in particular does not really seem to fit here. And so that just raises suspicion for me for a few other things. We know that a lot of supplements are either contaminated in general, which can be an issue. Although even that, still, there's a lot of issues with the timing here in terms of a contaminant that leads to this immediate set of symptoms that then you just like drink some water and chill out and it vanishes within a round. Still doesn't fit really well. Or a lot of these creatine supplements are not necessarily just creatine, but they're like creatine as part of a pre-workout supplement or something like that, which does have a boatload of caffeine in it or some stimulants. And caffeine can, onset and offset in relatively shorter order. Or lastly, like he ingested this and maybe he got freaked out by if he quote unquote inhaled a rock. It didn't end up in his lungs, but maybe he felt like something went down the wrong way, freaked out, led to some anxiety, some panic. And of course, golfers being in a sport where they are like super interoceptive, in tune with their, mental state, their bodies, their performance. It's very highly skill dependent. And so maybe, relatively tiny things can risk throwing somebody off their game a little bit. And then you can kind of spiral from there. I know you've described that before and seeing a lot of golfers describe this thing. So I think there are a lot of other potential more plausible explanations for this rather than like pure creatine monohydrate acute toxicity that resolved within just as fast as it onset, seemingly.
Yeah. It was interesting to hear. Yeah, I tend to agree with you. My two, like, if I was favoring what really happened and trying to come up with an idea, the two main things I favor, one is that it was actually like a pre-workout that had caffeine, and he happened to just overdose on caffeine acutely. Although the timeline doesn't exactly make sense, but at least there's some like physiological plausibility there. Sure. Or two, it's actually more a revisionist history thing. Like he got off to a terrible start. There was maybe, starts feeling anxiety. He's like, oh no, I have to perform well because I want to get on the Ryder Cup team. I want to finish strong. I want to make, do well. You can kind of spiral there. And then it just happened to have also ingested,
right,
whatever this was. But here's the thing though. There are no reported cases of creatine overdose, which is actually baffling to me, just given how common the supplement is. And you would expect that somebody would have, I took the whole tub, and like they get like some sort of like GI related thing where it just is all impacted or whatever. I don't know, something. It doesn't exist. It's not out there. No overdose. And that's different than a side effect. Also, just to clarify for the listeners at home, they're like, wait, I took creatine once and I got bubble guts. That's an overdose. I'm like, well, side effects are, these documented adverse events that can occur at, virtually any dose. And so, yeah, that's been described in creatine, particularly at higher doses, nausea, diarrhea, stuff like that, cramping. But overdoses are like an actual toxicity. And I think if you were trying to like define these words, you would say toxicity is some sort of severe medical event versus just like, your tummy hurts a little bit. So, contaminant that's possible, but probably more likely to just common things being common. A lot of caffeine, maybe that was the thing, or just revisionist history, and you got to confabulate a reason for why you sucked the first 3 holes.
Yeah, people do this, without even realizing it. A lot of times we look for, or we seek stories to explain our experiences. And so this concept of confabulation is more of like a medical term that's used in certain contexts, but humans do this all the time. We backfill explanations for all sorts of things in a way that seemingly makes sense, which is another interesting aspect of human psychology. So has he competed again since that tournament? Because I was not aware of this happening, or what's his status now?
Yeah, so this was the second round of the Race to the FedEx Cup. So basically they start with 120 players, and then they cut it down to 70, and then they cut it down to 30. So he made it all the way through, and actually this weekend is going to be the Ryder Cup. That's like every other year. Yeah, so he made the team. Big year for this guy, so we'll see how he does. It's kind of interesting. He plays with like aviators, like mirrored aviators, which is... They're not like sports like glasses, and it looks kind of funny on his face. But apparently he has some sort of eye condition. I forget what it is offhand. And yeah, he's been a stone cold killer this year. So we'll see. Nice. We'll see how he does.
Cool.
All right. Next, we're going to dive into the hot topic that is GLP-1 agonists. We got a few of these items on today's rundown. So these are the drugs like Ozempic and Wegovy that have become so popular for weight loss, and we know they're great at managing obesity, but what about their long-term effects? We get these questions all the time. Like, come on, we don't really know what they do, even though some derivation of this has been out for about 20 years, and we do have long-term data. That's besides the point, because a new study published in JAMA's Oncology Journal looked at their impact on cancer risk. The researchers conducted a large retrospective study following over 43,000 GLP-1 receptor agonist users and compared them to a similar group of non-users. And they looked at the incidence of 16 different obesity-related cancers over a period of about 10 years. So the study found that GLP-1 users had a significantly lower overall cancer risk, 17% lower to be precise, compared to non-users. And this is a huge deal because this is a promising result with reduced risk of endometrial, ovarian, and esophageal cancers, as well as meningiomas in the brain. However, not all of the findings were positive. They also saw that there was a non-significant increase in the risk of kidney cancer. So again, non-significant, but some signal there that maybe warrants some additional monitoring. So the question to you, Dr. Baraki, is how do we as physicians or people in this space weigh the risk-benefit profile when counseling patients about these medications, especially with respect to cancer risk? Is this something you would bring up, or just like keep this feather, in your cap for yeah, that's cool that this happens, but I don't necessarily need to talk to patients about it?
Yeah, this is not actually something that comes up in any of my counseling with respect to these medicines when working with patients. This data, it's one of those things that you kind of want to be true, but I think there's a lot of caveats to these types of studies. You mentioned it's a retrospective analysis, which itself introduces a number of potential issues that they can try to control for, but ultimately it's not possible to fully address all of these things. And so in several of these studies that I've seen, I haven't actually seen the data in the particular one you cited, but this is not the first in this realm where they kind of claim that these medicines are associated with lower incidence of cancer. But when you look at the incidence curves, for example, a lot of times the curves of those who develop cancer versus don't, for example, it separates immediately upon initiation of the drug, which is essentially an indicator that there is some bias in this study. Not bias like nefarious from the researchers, but rather something that's unaccounted for. For example, like what fundamentally is different between those who end up getting put on these versus those who don't, as an example. And so when you see that immediate separation of the curves in these studies of those who tend to get cancer who are not on GLP-1s versus those who seemingly get it at a lesser rate on GLP-1s, that's an indicator of a problem with the data, not that these drugs are so magical that within the first couple days or weeks, people are already experiencing less cancer. And so I am not confident in this in these sorts of observations. It's very plausible to me that over a long enough time period, if you manage to reduce the burden of obesity, that the incidence or the risk of obesity-related cancers might tend to decrease over time. But I am not as confident in the magnitude of effect that's reported of association that's reported in these studies. I would not be confident in like particular effects on particular cancers as reported in these studies, or certainly those where there's some non-significant increase in kidney cancers. Also not confident in that finding. We would need different types of data and evidence to show that sort of thing with a greater degree of confidence. So when I'm counseling patients on these medicines, none of this is really coming up in my conversations. You don't need to scare patients with obesity that they're more likely to get cancer in order to have these conversations effectively. I think people with obesity who are seeking care and seeking treatment for these things, oftentimes they're already aware that this is not the healthiest state for them to be in, and if they're not aware, then there are other ways to go about this conversation rather than using what I would deem to be not ideal observational data in the realm of cancer, when we have much stronger evidence, like randomized controlled trial level evidence of this reduces the incidence of cardiovascular events. We know it reduces the incidence and progression of chronic kidney disease. We have a lot higher quality evidence for benefits in other realms if we wanted to lean on those, whereas I don't actually buy this data yet at this point, mainly because of like I said, when you look at the curve separation being immediate, I'm like, immediately this is not useful to me right now.
Yeah, I mean, I am inclined to agree with you, with the caveat being I actually do think there is some cancer risk reduction. I just don't know that it's that big, or it could be bigger. Or,
Sure.
In more cancers. Or you see what I'm saying? Like, mainly because we do know that excess adipose tissue is certainly a risk factor. And so by reducing that risk factor, it intuits that, risk of developing cancer or disease burden from cancer would also go down. But yeah, exactly as you would mention, the curves, and you're just talking about these Kaplan-Meier curves where you would expect them to stay pretty tight, people taking the drug and people not taking the drug, and then later on split.
Mm-hmm.
If they split immediately, that means that either the intervention is causing additional either behavior change or some other sort of differences between the two groups, or the groups are just different. Right, something is happening that is not being picked up in the data set, and so when I saw all the mainstream media jump on this paper and be like, these things reduce cancer, is there anything they can't do? They probably make julienne fries, and it's like, well, I like the enthusiasm,
sure,
and I like anytime big pharma, especially today, kind of gets a win. It's not that I'm rooting for big pharma, as the cabal, but I'm kind of like, it's nice, to just have a feel good story here once in a while, rather than something sketchy in the mainstream media. So I liked the enthusiasm, but I was like, we have other positive things to report on with these medications, like you mentioned, cardiovascular disease risk, chronic kidney disease risk, all sorts of stuff, and so it could have been, I guess, couched in a more accurate way. Like, we have these known benefits, we have this relatively well-known safety profile, and it may reduce risk of developing cancer. This data is not super convincing, although the sample size was large, which I liked. Sure. And the follow-up period was reasonably long, although you'd want it to be longer. Just to me, this is just like it's like a road sign in the middle of your journey. It's like, look, we're partway there. It's signaling, trending towards positive, but we need some better data that's longer term and done a little bit differently, I think.
Yeah, I mean, I suppose you could frame it as, well, at least we didn't see a super concerning signal of harm that needs to be teased out further. I'm unconvinced on the magnitude of benefit or the timeline to benefit, and that's why this is not informing a ton of my conversations. But a lot of times these observational studies can be hypothesis generating in either direction for potential benefits or for potential harms. And at least we're not seeing, massive potential harm that was unaccounted for in this, because regardless of what you described, it intuits well that, potentially obesity related cancers might decrease. Our intuition and our kind of what seemingly appears rational, logical, that we might deduce, oftentimes fails to play out in randomized trials. So that's kind of where we are right now.
Agreed. All right. Another GLP-1 related topic. This is also a new study because it's a new drug. MariTide is going to be the name, which actually, of the anti-obesity medications, I'm
Easy
not
to
offended.
pronounce.
Yeah. What do we think this is?
MariTide,
cafraglutide. Okay, that's a soundbite. This new drug has been shown to produce about 12 to 16% weight loss in individuals with obesity, compared to 2.5% in the placebo arm, according to a recent phase 2 clinical trial. Now, that's not news, because Zepbound, tirzepatide, this is not like groundbreaking weight loss, but it's in a once per month shot, which is actually groundbreaking. Now, as far as how this drug works, it's most similar to tirzepatide, which is Mounjaro or Zepbound, in that it targets both this glucose insulinotropic polypeptide, or GIP receptor, and also the GLP-1 receptors. However, it's different in that the drug contains an antibody against that GIP receptor, whereas tirzepatide actually stimulates that receptor. So we're going to talk about that for a second. Also, MariTide has 2 GLP-1 receptor agonists, whereas tirzepatide only has 1. So slightly different, but similar kind of structure. So it is kind of interesting. It's like one of these drugs, tirzepatide, actually stimulates this GIP receptor, whereas this new one, MariTide, actually antagonizes it. And so when you stimulate the receptor, activate this GIP receptor, the mechanism is thought to be based on this appetite suppression kind of thing. It's similar to the GLP-1 receptor. And so if you stimulate it, you get a reduction in appetite. There's also maybe some neurobiological effect where your brain is more sensitive to energy balance, which would go into that appetite suppression kind of thing. But if you block it, like this new drug MariTide does, there's some thought that this basically blocks fat storage or reduces fat storage by influencing what's happening at the level of the fat tissue itself. And then you also get the appetite suppression from the GLP-1 part of this drug. So it's kind of interesting. It's like you can get benefits from doing anything to GIP, Like
Yeah,
it's just hanging out there. It's like, hey, do something to me. I'm gonna do good.
Yeah, and the idea, and one of the interesting things is, all these are normal endogenous things that we all have, yet these meds, the way they end up delivering such high degrees of efficacy is by increasing activity at those things or blocking activity at those things way, way, way outside the bounds of like what normal. So the point of this is that, a lot of times people will see maybe in these social media posts or in certain advertisements or people hawking certain supplements or dietary strategies to like increase your
Boost
natural
your
quote unquote GLP-1. And it's like, you are not even getting within a couple orders of magnitude of what these meds can do. And so the degree of effectiveness that you're going to see as a result is going to be similarly unimpressive in comparison.
Yeah, there's actually, and I believe in one of our articles on these medications, I discuss actually the difference between like gut generated GLP-1 and then when you the difference if you take the medication and add the levels in the brain. Yeah, it's orders of magnitude different. Like you could do every biohack possible to raise your GLP-1 levels.
Right.
And then you could take the lowest dose possible of any of these medications and you'd see, again, orders of magnitude difference in GLP-1 levels. In any case, this is pretty interesting. This drug, mainly from an adherence standpoint, I tried looking up like what was the adherence for people taking like Ozempic or Wegovy, same thing with Zepbound, once a week, whatever, and just seeing like how many times on average do people miss a dose, right, or skip a dose or whatever. And I couldn't really find any good evidence there. But generally speaking, there's this inverse relationship between the frequency of medication administration and adherence. And so I guess I wouldn't expect people who are taking these anti-obesity medications to be missing doses regularly. People are pretty motivated to take these things. But I'd also just get your take on this. Do you think this is a big, potentially a game changer with the once monthly dosing compared to weekly?
Yeah, so interesting topic here because we have a lot of experience with other types of medicines. And in general, when I'm prescribing meds to patients, higher frequency dosing in general makes it harder and harder for people to stick with it. So there are certain meds, for example, that I can think of, certain antibiotics, for example, that are like 4 times a day. Mm-hmm. And it's like, gosh,
Good
even
luck.
I would, suck at taking that every 6 hours around the clock or something like that. And then we have longer and longer acting meds that might be once a day or once a week, once a month. There are even some, like there's an osteoporosis medicine that we dose people once a year. You just get an IV infusion of it once a year and you're set. And so there are pros and cons to all of these things. The pros obviously have to do with convenience and sustained effect, particularly for patients who might have unique difficulties with adhering. This is also the case in the realm of certain psychiatric care with schizophrenia and things like that, where you want to be confident that the patient's getting treatment and less likely to miss doses, leading to relapses and issues like that. On the other hand, when you have a medicine that is very long acting, there can be 2 issues with that. The first is that it takes longer to reach your kind of steady state level of medication activity. So it takes a little bit of like loading time to get up to the right levels in the system. That's not as big of a concern, but it's just something that we recognize. The other, though, is that depending on the dose that you start with, if you end up starting too high and the person experiences side effects on too high of a dose that they get up front, you cannot easily adjust the dose as quickly, right? And so the extreme version of this is like where I tend to work, be it in a hospital or an ICU type setting, where I have a medicine that if I stop it, it's out of your system in like 2 minutes. And so I can tweak the dose very fine-tuned to get exactly what I want. Whereas if it's a medicine that's going to last in your system for 3 months and I load you up with way too much up front, it's like, well, this is going to suck for a little while, and before we're able to adjust things. This is also, for example, why in throwing back to some toxicology, when patients develop vitamin D toxicity, if they take way too much vitamin D and it accumulates in their body fat and they have super high vitamin D levels that lead to the consequences of high calcium and all sorts of other things, it can take months for that to get better because it's all accumulated and it's long lasting and it's stored up in their body fat and it's slowly being released that way. And so my, concern, if I were initiating a patient on a medicine like this, because we know that upfront at the time of dose initiation of GLP-1 agonists, and with dose adjustments going up in dose, for example, at that time, patients might have a little bit more of the gastrointestinal side effects, particularly among patients who are a little bit more sensitive to them and before they fully adapted to these meds. So they might have a little bit of GI, stomach, discomfort, or some nausea, or some constipation as somewhat common effects, depending on the dose, the person, the frequency of dose escalation, and things like that. And so I would want to be extra careful with a medicine like this, not to start out too high too soon or escalate too rapidly, because again, I suspect that the effects might linger longer compared with if I were giving you medicine that's once a week, where patients still might have issues for a few days. Or if I wanted to go way back to, liraglutide, which is once daily, I could adjust the dose once a day. But at the same time, the trade-off is that those medicines are way less effective. So I think that the dose finding, dose ranging, adjusting, tweaking, titration with patients is going to require a little bit more careful strategy in these medicines that are longer and longer acting. On the other hand, we have experience with other meds in this space. There have been long-acting formulations of insulin, even, which is a much higher risk drug to be using with patients in terms of risk of low blood sugars that can be dangerous. And yeah, a couple of years ago, they came out with a once-weekly long-acting insulin, which scared me as somebody who uses mainly short-acting stuff in a hospital setting. But when it's been researched, it's actually pretty effective and not that much higher risk of low blood sugars in patients. I suspect, of course, you have to know what you're doing when you're dosing this stuff. So more research, more practical experience will lead to proper dose finding and titration strategies. So those are some of the pros and some of the cons with medicines like this that are much longer acting.
All right, I got 2 questions, and we'll move on to the next one. So you mentioned, yes, if you overdose, the dose is too high, then you're kind of like up a creek because it lasts so long. But what if that is actually a feature and not a bug? Not to overdose people, but say, for example, people routinely around the time of injection, for whatever reason, have, with semaglutide or tirzepatide, they have nausea for a day or two, right? Mm-hmm. But then the rest of the week, they're fine. But I imagine if that happens enough times, they might start skipping doses because they're like,
Sure.
I really don't want to do this. Yeah. And so there's less coverage, right? Mm-hmm. And so now, okay, look, you're still going to get maybe a couple of days of nausea, but then the rest of the month, you're killing it. It's great. So maybe that's a feature. You think that's plausible?
Plausible. I think the factor that would differentiate it as well because it's a longer acting medicine, do those side effects last longer up front? Mm-hmm. Right. And that would be that we'll just have to see based on experience once we start using this stuff, assuming this makes it. I mean, this was, I believe, a phase 2. And so it still has a little bit more to go before we might be able to use something like this. But if it gets there, we'll see. Yeah.
All right. Second question. What side of the GIP coin are you on? You want to stimulate it or you want to block it? Or maybe both. Can you, at some point, there's going to be a medication. It's going to have multiple GLP-1s attached to something that blocks GIP and the other one that some of the time stimulates it because we've refined this physiology enough. But yeah, curious, you going to put your money on one side or the other on this GIP situation?
No, I'm not, because I don't know. I'm a clinician, a clinician, and not a basic scientist. There are a few other medicines out there that have this interesting kind of partial agonist or mixed agonist antagonist type activity, but that's getting a little bit further down into the weeds of pharmacology and things like that are both outside the scope of this podcast and outside the scope of my expertise. So I don't really know what we want to do with GIP, but I trust that the people who are most incentivized to figure that out are going to.
Yeah, I just think we need to tickle it. That's
sure.
We just tickle GIP, do something to it, and it's great. We got a benefit for you. Yeah,
sure,
nice. All right, next, LeBron James does a silly exercise. Did you see this video?
I've seen. I think it was him doing some kind of deadlift, if I recall the video that you're talking about.
Yeah. So this is none other than 4-time NBA champion LeBron James, and in this video, I'll put it in the show notes if you haven't seen it. He's in a gym performing what can only be described as a snatch grip sumo stance Romanian deadlift with about 165 pounds. You should know that the weight is light enough for him to actually swing the bar away from himself at the top of each rep by a few feet. Yeah, no, a few feet, not inches, like feet, okay? And speaking of feet, he's wearing Vibram 5 fingers, which are only good for chastity purposes. So interesting that he's wearing those. And more interesting than that is Alico felt compelled to repost this because he's using an Alico barbell and weights. So the controversy that kind of erupted from this is not just about his form, though. It's the fact that LeBron James, who has access to the best trainers, presumably nutritionists, physical therapists, whatever, he has access to all this stuff. Why would he do this specific lift? Like, who taught him this? There's no way you go into the gym and you're like, I'm going to adopt this wide stance and an even wider grip and then do a partial deadlift with a weight that's light enough that you can like hip thrust it away from you while standing. But on the other hand, he's been in the league for like 20 years, so maybe we should all just shut up and not, just move on by this video. So I don't know. What do you think about this? How did LeBron get here to this particular exercise? Do you think that he just came up with it, and because he saw somebody else doing it or somebody told him to do it? How do you think this happened?
I would be surprised if he is making his own lifting decisions with the resources that he has access to in terms of his coaching and strength and conditioning and, physical therapy and all the other things that he presumably has as part of his general routine for strength and for conditioning and for kind of rehab and maintenance and performance and sports psychology. Like, I bet that he, has access to resources in all those realms. So I don't think that he necessarily arrived at this at all. It would be interesting to hear what the coach who prescribed this was thinking. But at the same time, I know we've seen all the usual arguments around this kind of thing over the years. There's on one hand going to be folks who are like, this is the dumbest thing I've ever seen. This is more so coming from, lifters, I suppose, oftentimes like us, who are like, this is dumb. This isn't the way to do it.
Deadlifts.
Right. Here's a more effective way to do this exercise. Or the pushing that to I think the more egregious level would be like, he would be so much better if he did it my way. Right. Yeah. Which we see that kind of thing. On the other hand, there's people who might argue, well, over the course of a couple decades doing this kind of thing, maybe they have gravitated and figured out something that quote unquote works for him. And then I think there's an in-between position where it's like, this is probably neither helping him that much, nor is it likely harming him that much. And he is such a freak athlete in so many other ways that he is able to perform well. And this is like, fine. This is like not substantially moving the needle. In other words, if he were to change and maybe, instead of doing this weird squatty snatch grip RDL type thing, but he actually did an RDL, or he actually did a squat or a deadlift, would we see a difference in his performance on the court? Would he score more points, right? To use like, when we talk about mechanisms versus outcomes and things like that, it's not about like, is this putting the right amount of muscular hypertrophy or strength stimulus on his hamstrings or his quads or his adductors or something like that, but rather like, is there some relationship between this and his points or his rebounds or his wins or some statistic that actually matters for the sport? And for somebody who is as freaky as him, I suspect that there are probably a whole lot of things that you could do in the gym that would maybe not move the needle as much as maybe lifters like us would like to think, because we want it to be like, lifting is so critically important. But man, freaks are going to freak at a higher level. I remember seeing this back in my swimming days. There were some lifting was not a big part of swimming kind of training, and then gradually over time we saw it grow, and we started to see swimmers like Ryan Lochte, for example, started to get a little more popular. There were videos of him doing, pulling chains around and doing tire flips and things like that in the gym. And then, hang cleans, which was like, radical for the sport. Super, super different.
Mike Boyle just took his shirt off.
Yeah. But these guys were already at the top of the sport, seemingly. Of course, some of the strength I do think helped them in certain ways, but there's a lot of ways to develop strength, including using lifts that are not traditional. And so I just don't really, I don't know the value in hyper analyzing the precise things that the absolute like people in the stratosphere of sport are doing as a way to draw any sort of conclusions about what anyone else should do. I think that once you have defined your individual training goals, then we can talk about the pros and cons of different ways to get there. But I just almost see like no external validity from what LeBron James does to what you or I or anyone else listening to this might be inclined to do as part of their own training.
Yeah, I'm inclined to agree with you. I mean, I think if you're a sports scientist, if you're a coach, right, you have to have some sort of method and central like paradigm to organize your thoughts about how you go about choosing an exercise. And so, there's basically two poles here. One is like specificity, and the other one is like a generalized exercise. And so depending on how you approach, okay, where are we at in the season? What are we looking to develop? What are the goals of this program? You would pick, something on that continuum. This is kind of like none of those things, you know. It would, if you had to, place it on that continuum, it's definitely towards that generalized type approach. And I guess if I had to, confabulate to throw back to that term, a reason for why this quote unquote works for him, it's kind of like maintenance muscular force production. He's like applying some force against an external resistance that is whatever, preventing him from otherwise detraining with no exposure, right? Comparatively, although it is very light for him. So like, I don't know, man. The weighted stretching, we could call this.
Sure.
Right.
Yeah, exactly.
but to your point, somebody definitely told him to do this, which is maybe more concerning, because it's like that person either has no familiarity with a deadlift or any real hinge pattern, or like the Olympic lifts, or apparently footwear. So I'm like, how did this person get into this position, right? Because very, very interesting. As always, success leaves clues some of the times, but often freaks do well in spite of the stuff that they do. So like, to your point, I don't think that anybody who's aspiring to be in the NBA should be like, that's the deadlift variation that I need. If I had to pick a deadlift variation, it would, an RDL would be fine, a rack pull would be fine, a trap bar deadlift would be fine, and some of that stuff should be done at high velocity. Alternatively, and maybe this is a hot take, if you are not a barbell sport athlete, you don't have to deadlift. Like, if I saw LeBron James doing like hip thrusts and and the caption in my perfect world is like, this is the hinge pattern that I do a few times a week, I'd be like, great. You're loading the body, you're whatever. But he doesn't need a deadlift. So
you mentioned that success leaves clues, and it makes me think about a little bit of our approach in, say, clinical practice or in coaching practice, to the extent that we want to rely on any degree of evidence. And there's almost no situation where a single piece of evidence or a single example, or even like a case report of one person experienced this thing medically or in the coaching, training, performance, where one single example is going to change how we do things. It's much more so an accumulation of evidence, a larger body of evidence. And so this is the same thing here. To the extent that success leaves clues, I think that we tend to see it more often in larger cohorts of high level competitors, right? Recognizing the general, these papers that look at, for example, Olympic level endurance athletes and their general training, what are the patterns in their training setup, their intensity distribution, their volume tendencies, things like that. Of course, there's always going to be outliers. And those are maybe the freaks who either have some aspect of their physiology that has not been defined, or some genetic mutation that makes it so that some particular way works best for them. Maybe they're really good in spite of what they do theoretically, although unlikely at the highest levels of sport, or maybe it's just good enough for them to beat the rest, right? I think back, for example, you see pictures of Mark Spitz in his original Olympics swimming the fly race, and it is like the most horrendous butterfly technique you've ever seen. Well, and then you fast forward a few decades, right? You fast forward a few decades, and you see how sport has evolved and how swimmers are executing it, so much better and more efficiently and lower to the water and propelling forward and not up and down and things like that. But if you had looked back at the time and critiqued his technique, people would be like, well, clearly it works. Well, this stuff is always in a state of evolution and flux, right? One way or another. And so that idea of success leaving clues, it's not one person doing something a particular way, but just the general evolution of sport as competitors, who are those who are most incentivized to figure out the best way to do things, actually do that.
Imagine if you're Steph Curry and you you're doom scrolling, because like he probably does, and he sees this and he goes, oh man, I got to be doing this exercise.
That's the trick. Yeah.
Yeah. Shoot. Anyway, so I thought that was funny. If you haven't seen this video, it's in the show notes. All right. Next topic: when ChatGPT goes wrong. So this story is a cautionary tale. It's making waves across the medical community and beyond. So what happens when you ask an AI chatbot for health advice? The answer, in one man's case, was a 3-week stay in the hospital with hallucinations and paranoia. So in August of this year, a 60-year-old man who was looking to cut down his salt intake from his diet, he asked ChatGPT for an alternative. ChatGPT reportedly suggested sodium bromide, which is still used in veterinary applications for epilepsy in dogs and cats. It's also used for some water treatments, as well as processing film, and by the oil and gas industry to stabilize wells. Now, in medicine, sodium bromide was originally used as a sedative and an anticonvulsant in the late 19th and early 20th centuries. However, its use in human medicine has declined due to concerns about toxicity. We actually have a podcast, a medical mystery case, which is no longer going to be a mystery to you if you listen to this. So maybe like
This was episode 299. It's a good one.
Just go back 15 seconds and like neuralize yourself, and then you can go listen to that episode. So in any case, the chatbot's response may have been intended for other uses, but the man took it to mean that he could use sodium bromide as a salt substitute, which he did for 3 months. He was admitted to the hospital with a variety of symptoms, including hallucinations, paranoia, and a claim that his neighbor was poisoning him. Doctors initially considered a psychiatric cause, but eventually diagnosed him with bromism after consulting the poison control. I mean, honestly, the fact that this took 3 months to get bromism is pretty impressive to me, because normally it's like, oh, you started doing this, you started taking in sodium bromide at any sort of significant quantity, and you're like, oh, shoot, you got the bromism. So the question to you, Dr. Baraki, just the convenience of AI and ChatGPT, stuff like that, it's undeniable, especially for answering some questions that have already been written about on the internet. But at what point does it become a liability? Like specifically, if people are using this for like self-diagnosis, what are the dangers surrounding that? In addition to the benefits, right? Like you can imagine somebody is just on a fact-finding mission, and that may be beneficial, but I don't know. Do you see some harms here?
Absolutely. There's no easy answer to this. It is both a convenience and a liability. And it is not, there's no simple heuristic by which you can differentiate when it is which. So part of the issue, for example, is I could take a hard line and say, absolutely not. People should never use these tools. You should only see a doctor, a human doctor like me, whatever the case is. But then there's going to be people who are like, well, I have this condition that nobody could really figure out after, seeing multiple doctors and specialists and a lot of testing. And, I spent some time reading and researching and putting stuff in, and I managed to come across this diagnosis that they hadn't heard of. And when I presented it, it ended up being the correct diagnosis. And it's like, yeah, I can't argue with that. Like doctors are humans too. We have limited human brains. They have the benefit of, a lot of dedicated training and experience with things, but that also means we also have biases and blind spots and things like that. And that's why medical education takes a long time. And, my style of medical education also draws attention to things like, the ways we think and biases and where there can be these types of blind spots, and also figuring out ways to use these tools to enhance our skills and our performance and our accuracy and reduce the amount of harm that we might cause. So using these tools kind of responsibly is actually something, I've done some formal training in the past year in the use of these tools in the context of medical education, and as well as in practice. So there's not an easy answer here. There is obvious risk with, a patient kind of on their own using these tools without any maybe requisite background knowledge or understanding or training, and then acting upon it, right? So I think that there's a big difference between doing this kind of research. Say you come across some diagnosis or some health strategy, and then you just send it and you go all in on the strategy that the large language model suggested to you, compared with if he had, for example, done this and then he also had a backup of, okay, next time he chats with his doctor and he's like, look, I've been looking for strategies to improve my health. I feel like, maybe for this reason or whatever, that some reducing my total daily sodium intake may be beneficial. First of all, is that true? Second of all, is this a wise substitute for that? Because there are sodium substitutes for those who want to reduce or replace their sodium intake with more healthful options. This has been studied. There's some randomized trials of potassium-based salt substitutes, light salt, reducing the risk of stroke and some other things like that. Not to say that everyone listening to this should go and substitute with potassium, because there's some potential risks to that need to be kind of dealt with on an individual basis. But any doctor who was, let's say, worth their salt. That was painful to say. Oh, but he goes and talks to somebody, consults with them on this. They'd be like, "No, dude, don't do that. That's not a good idea. Here's a safer alternative," and he could have avoided all of this. So yeah, I think they are both a benefit and a liability, and on a individual unilateral basis for untrained folks using these to make active health management decisions, I feel like that probably falls slightly more on the risk side of the spectrum than the benefit, outside of very obvious issues of like asking your large language model whether losing some body fat or improving your sleep would be good for you. But these sorts of kind of higher stakes decisions, I don't love people doing this unilaterally without some additional input.
All right, so a couple of follow-up questions before we move on to the next part. Thing one, if this is a large language model, then presumably it's just scouring the internet, crawling the internet for stuff that people have written about related to this question.
Yeah.
So does that mean that somebody out there or multiple people out there have published this idea like, hey, stop using table salt,
Right.
use sodium bromide? Right? Like, where does it come from?
Exactly. Yeah.
Is it hallucination or is this real?
That's kind of what I'm wondering is, these things are known to hallucinate. And if this was more of a hallucination than anything, because, a lot of these will spit out linked references or like, where did this come from? And so I'd be curious where to go down that rabbit hole and see how it came about if that's identifiable. But these hallucinations
or
these things
Antonio.
are definitely dangerous. I've had patients already, that I work with who take their labs and they punch them into one of these things, and it might give, correct interpretations, or it might give interpretations that are problematic. And when I read the chat model's interpretation, I'm like, I can totally see how it got here, but that is actually incorrect for this patient's situation based on what I know about them. It might be that I know more about the person, I have more context, I know more of their background. This just happened to me pretty recently, and I read the output of it, and I was like, yeah, I see how it arrived at all these conclusions. But this is like first year, second year medical student level interpretation of these labs to the point where it's actually incorrect, and it takes a bit more experience and knowledge of this person to know how it does and doesn't apply to them. But it was like too late because it had already freaked the patient out, and so these things do need some expertise to work through. I'm sure these models will get better with time, but I don't know. It's a little scary sometimes. Although in other areas of my practice, I have made some use of these tools as well. So that's why it's such a messy area. There's not a clean answer of like, yes, we should be going all in on these things, or no, we should never touch them and just stick with human doctors. It's like, no, I don't think that's a realistic future.
So the last thing, I swear to you. So this is the last thing I'm going to say.
Yeah.
If a patient asked you, Dr. Baraki, I want to cut down my salt intake. I think I'm going to take like a sodium bromide instead. And you were like, sure, send it. That would be grounds for some sort of malpractice, suit.
Totally.
So is Chatty G going to get, sued here?
Sam Altman.
Yeah. I mean, what do you think about that? Or like the people who published this stuff that the language model like interpreted, if it wasn't a hallucination, right? Imagine if Mercola had posted this on his website, or Danicola Antonio, idiot surrounding sodium intake, just generally speak, maybe just idiot in general.
Sure.
Full hate, sending hate from California. Like if you put this out there and it does cause harm, like what sort of, recourse is there?
Yeah, I'm not having any legal knowledge or background. I don't know. I think it is a question that will at some time point going to need to be addressed. It reminds me of, some of the legal concerns in the social media space. I believe it's called like Section 230, having to do with like, are these social media platforms, are they just a platform for people to put things up, or are they the publisher of the information? And so as a result, what sort of liability do they have? For example, if somebody decides to act on some information on there, be it, some sort of attack or violence or something like that, do they have any liability a responsibility for that, or are they just serving as a platform for people to put up whatever they want, and the liability there falls on the individual? In this chatbot realm, there isn't really a clear individual that we can like lay such blame at the feet of, and so it'd be not that it would be. I think it will be interesting to see when this almost inevitably gets tested in the courts if something like this happens, and I suspect that there would be just absolutely gargantuan, aggressive legal tactics and lobbying tactics and things like that on behalf of the companies to more strongly limit their liability, because if they were deemed liable, then that almost shuts down the whole enterprise, because there's no way that they can realistically exert control over what these things tell people. And so that's, in our, I don't know, maybe approaching dystopian internet society, that may be the way that it ends up playing out. But you're right that it's a question that ought to be answered. I just don't know that it's going to be answered satisfactorily for like patient safety and things like that.
I wonder if people will support, the companies that have these large language models and like, hey, look, they can't be held liable, and how many of those people do not feel the same way around vaccine manufacturers.
Totally. Yeah.
Interesting. Okay,
Onward.
Next topic. This is on plant-based diets and blood pressure. The American Heart Association has been in the news recently with new studies linking plant-based protein to lower blood pressure. The MAHA study, which just came out, analyzed data from about 2,300 participants who were between the ages of 45 and 84 from a diverse background. It's probably one of the strengths of this study, the diversity of the individuals. All participants were free of high blood pressure or hypertension at the beginning of the study. And they completed this 120-item food frequency questionnaire at the start of the study to assess their usual dietary intake or dietary pattern. And they were followed for a median of 9 years. Incident hypertension or high blood pressure was defined as a blood pressure reading of greater than 130/80 millimeters of mercury, or the new use of a antihypertensive medication. As far as the findings, the researchers found a clear inverse relationship between plant protein consumption and hypertension, meaning that the greater amount of minimally processed plant protein sources were associated with a lower risk of developing high blood pressure. The researchers did mention the potential for a, quote, threshold effect where the benefits plateaued after a certain amount of consumption, but there was no statistically significant association between the quantity or variety of minimally processed animal protein intake and the risk of high blood pressure as well. So I thought that was an interesting finding. And finally, they also found that highly processed plant-based options were linked to a higher risk of high blood pressure. So, question to you. What do you think the mechanism, the mediating mechanism is here? Do we think there's something in the plant proteins themselves that's causing this unique, antihypertensive effect? Do we think this is just a reduced energy intake because people who follow a vegetarian or vegan diet tend to eat less calories by, quite a substantial margin? Are there other confounding variables like, you're more likely to eat, if you eat plant-based proteins, you're more likely to exercise or something like that? Is it the level of processing since they found those relationships? What do you think the mechanism is here?
Yeah, I'm going to give a maybe unsatisfying answer and say it's very likely to be a combination of all of these things because the way that this study was designed doesn't really let you identify a particular mechanism. All of these, in other words, the results observed in this study would seem to be compatible with any or some combination of all of those mechanisms that you just described, right? So on one hand, you could say, well, people who, this whole healthy user bias, those who tend to eat plant-based diets tend to be healthier on average, but that does not mean that it is impossible to have a generally healthful dietary pattern that does include animal products. And I think that that's a position that we would mostly sign on to, depending on some more details and a matter of degree. But we also know that there are plant-specific compounds like what are the general category of phytochemicals that have a whole bunch of health benefits, both defined and as yet undetermined, on things like systemic inflammation and vascular health and function and insulin sensitivity and all sorts of other factors. So there's a plausible mechanism of benefit there as well. You mentioned the energy relationship. That's probably the easiest one to figure out just by looking at if that was data that was collected in the study of did those who were on the plant-based diet, did they, have, say, lower levels of body fat, lower waist circumference? Did they tend to lose weight if they switched their dietary patterns, et cetera? So that may or may not be as much of a factor depending on what the actual data set looked like. So there's some plausible evidence of, some plausible mechanism of confounding, some plausible mechanism for overall energy. I do buy that having a more plant predominant dietary pattern is just generally more healthful in a variety of ways compared to many commonly consumed diets that include higher amounts of animal derived food sources. Again, I don't think it's impossible for somebody to have a health promoting dietary pattern that includes some degree of animal derived products. Now, if that is the entirety of their diet, the most extreme example being like carnivore or something like that, I think that both of us are going to stick by our position that is not the most healthful dietary pattern, and those folks would stand to benefit greatly by introducing more and more plant-derived food sources, both plant-derived proteins as well as other plant sources of foods. So that's my take. In general, when I'm assessing a patient who has concerns over their blood pressure, who has newly elevated blood pressure, I'm taking a general dietary history on them, like 100% of the time, and then really getting a sense based on their level of self-efficacy, their readiness for behavior change, their motivation, and what are the highest yield targets that I can attack. And so, it's typically going to be like, does this person consume a high amount of sugar-sweetened beverages? Do they consume a lot of alcohol? As a couple things that I'm going to target right away. How's their sleep? What's their waist measurement? And then from there, going down the dietary quality piece and seeing what things I can substitute. Not specifically because I might have evidence that if you substitute this food for that food, it'll lower your blood pressure, but rather we have good enough evidence to say that if we substitute this food for that food, we're going to improve the overall quality of your dietary pattern. And as a result of that, as well as many other things, we can expect some improvement in blood pressure and many other important health parameters over time.
Yeah. Yeah, the biggest takeaways for me on this, the finding that a higher amount of minimally processed plant protein is, generally beneficial for this particular metric is not surprising. You could replace this metric with like lipid levels, blood sugar control, whatever. I'd be like, yeah, we kind of already knew that. The main interesting points here was that there was not a relationship between the intake of minimally processed animal protein, which is kind of nice to, again, another little that fits my bias. I like that. And then also that highly processed plant proteins were associated with an increased risk of high blood pressure, which I think when people consider vegetarian or vegan options, just most folks would say, yeah, this is healthier than this other option, which is probably not true if it is highly processed, especially if there's like added sugars, added sodium, stuff like that. That would be the main point. And we'll come back to that specific question about processing in just a few questions. All right, next question. We're really doing some trigger warning type stuff here.
Sure.
We're talking about sex testing in sports yet again. So gender eligibility in elite sports has been a contentious and complex issue for years, but a major shift is underway. World Athletics and World Boxing are leading the charge by implementing mandatory one-time genetic testing for female athletes to detect the presence of the SRY gene. Now, the SRY gene, which stands for sex-determining region Y gene, is a specific gene on the Y chromosome. It is a critical factor for male sex development. In a developing embryo, while you're in utero, if you've got XY chromosomes, typically the SRY gene triggers the formation of testes. The testes then go on to produce hormones like testosterone, which lead to the development of male characteristics such as increased muscle mass and strength later on when people go through puberty. So this move is being hailed by some as a necessary step to protect the female category, despite it being called the women's category in most sports, but that's an aside, while others warn of the potential for discrimination and harm. So the question is this like a good fit to determine eligibility for the women's divisions? Just a brief history before I get you to weigh in, because I am interested in your take on this. We did this before, not we, like you and I, like went around testing all the athletes, but like in sport, this was done. 1996 to 2000, the IAAF, which is now the World Athletics, and the IOC, the International Olympic Committee, decided to use a genetic test for the SRY gene. They would swab people's cheeks to distinguish them from male from female. And this was used at the 1996 Summer Olympics in Atlanta, Georgia, where 8 of the 3,300 female athletes failed the test. So they were found to have an SRY portion, although all were allowed to compete as women. Now, in the year 2000, the IOC decided to abandon this testing, this universal testing, in favor of a, quote, suspicion-based approach where athletes suspected of being men competing in the women's division would be tested. This was mostly done by like the physical appearance, like, oh, your shoulders are too broad, or breast development isn't what we would expect, stuff like that. So this suspicion-based approach ultimately led to officials subjecting athletes like South Africa's Caster Semenya to testing and public scrutiny. Now, she's a South African runner who dominated the 800-meter distance on the track, and she was born with what's known as DSD, or difference in sexual development, disorders of sexual development, which means that she's got an XY genotype, but was legally registered and identifies as female. Basically, this intensified after the 2016 Olympics in Rio, where the World Athletics introduced a rule requiring DSD athletes to reduce their testosterone levels in order to compete in certain events, which required Semenya to basically take a medication to lower her testosterone levels, and she refused to follow that, arguing it was a human rights infringement and it was discriminatory. There's a long legal battle, including a challenge at the Court of Arbitration for Sport, which she ultimately was barred from competing. So she effectively missed most of her career due to this. So with this new policy, if an athlete's test is negative, meaning they don't have an SRY gene, they're eligible to compete in the female category. However, a positive test indicates the presence of an SRY gene, which basically means that they cannot compete in the female division. So what do you think about this? Is this like a good move, bad move, just, one or the other, binary?
Few things are. I truly don't. I don't think I've ever arrived at a point where I would say I feel very confident and have very strongly held opinions on this. And this is for a lot of reasons. But, we've talked a little bit about this before as far as how sports are arbitrary. They are made up. And every sporting organization gets to decide how it wants to set up its rules and its policies and its divisions and things like that. And so if a sporting organization says, here is going to be the way that we divide competitors up, we put them head to head in this way versus that way, the organizations can do that. I am not sure that this is a fundamental human rights issue. And I'm not saying that to say that it isn't. I don't have expertise in this realm of human ethics and human rights and things like that. And so, for example, in powerlifting, if one federation did this, you can go compete in another. Of course, that's probably less of an option at the highest level of sport on an international level for track and field and things like that, which is probably the counter argument to that is where else would this individual go? I also find it interesting from the more kind of biological standpoint at how much we fixate on particular deterministic variables here. And that's also because in the same way that sports can set up divisions arbitrarily, these choices are also to some extent arbitrary in the sense that there are a lot of different biological variables that have impact on human performance. And we are choosing to stratify or divide people along very particular ones, like, for example, their blood testosterone levels. We don't have different Olympic endurance events stratified by what is your baseline hemoglobin level, which is also something that is going to be heavily influenced by all sorts of biological variables. Like, we don't have the hemoglobin over 15 grams per liter division, the 10 to 15 grams per liter division, and then those the race for those who are naturally or for whatever reason more anemic, just as an example, or stratifying people based on their pulmonary function test performance or something like that.
Just a not to push back, because you are correct, we no longer do that. However, prior to the introduction of the biological passport in 2002, there actually was in some sports an upper level on hemoglobin, like the UCI previously had a limit on this. They were like, look, you cannot compete if your hemoglobin levels are higher than this. But anyway, we no longer do that. And you're exactly right. We don't have if your arm's this long, you can't, be a thrower or pole vault, something like that. We're making these arbitrary distinctions.
That's the point. It's not actually shocking to me that a sporting organization did that. And it's also illustrating how arbitrary this is, that it could have been hemoglobin, it could have been testosterone, it could have been pulmonary function testing, it could be arm length, limb length, mobility, metrics for certain other sports, whatever the case is. And so that's why I'm I think that it's almost like we have this ecosystem of sports that are going to trial a whole bunch of different strategies and see which ones, quote unquote, work to achieve whatever aims they have, which ones end up being more trouble than they're worth, which ones have unintended consequences, which ones are a disaster. And it's kind of like this continuous process of evolution over time. I don't know, again, I'd be curious as to your thoughts, or if there are experts in this realm. I think you interviewed Roger Pikey before on this, who he has a lot more kind of knowledge of this space. But is it generally thought of that this level of participation, is it a human right to be able to do this thing? I'm not so sure about that, even though it doesn't feel great to exclude people or potentially to recategorize people based on these things. But again, we're choosing to participate in a kind of a made up endeavor here. So I'm not sure where the right answer lies.
Yeah, I definitely don't know what the right answer is. So I have a few thoughts on this. Thing one, on one hand, I kind of want to applaud World Athletics for actually making some sort of policy relating to eligibility in particular divisions, because most sports, if you look at their rule book, they do not have these, which presents a problem when you run into these. You could call this like a fringe case, because look, just in the wide world of sports, in the women's division in particular, this is a very small proportion of athletes, although it is overrepresented compared to the general population as far as individuals with DSD, disorders of sexual development. But having a policy, even if it's the wrong one, you need to have something there. Yeah. It can't just be like, yeah, we'll sign up. You sign up for whatever division you want, and we'll shake it out later. Like that's probably not going to work. But on the other hand, I do have concerns about using this SRY gene. I think it's fine for determining genotype, like that's it, pretty good at that. But as far as eliminating women with DSD from participating, period, I don't know that that's the right policy, mainly because the connection between performance in women with DSD who do happen to have a Y chromosome, or at least a portion, the SRY portion, that's not been well established. It's not like, look, if you've got this SRY gene and you are a woman with DSD, your performance level is on average 15% higher, or 50% higher. If that were true, okay, well, look, I kind of see your point now. Like, we have good evidence, robust evidence, and from a fairness standpoint, I kind of understand that. That said, if you look at the charter, the Olympic charter, they do say that, look, everybody should be able to participate in sports. But so maybe then we need a third division, for example. That's an alternative policy. I think the reason why this was chosen is because there's a presumed connection between the SRY gene, testosterone levels, and then subsequent performance. But even the relationship between testosterone levels and performance in both women and men is not super clear cut. Yeah. And in fact, I thought it was interesting that the guy who discovered the SRY gene, Dr. Andrew Sinclair, I believe he's out of Australia, he said, "Mate, this is overly simplistic." That's my worst Australian accent.
Yeah, not great.
But he said that, and I'm like, look, the dude who discovered this gene is telling you, like, hey, maybe this isn't the best policy. So I don't know. I think they could have released this in a different manner and said like, look, we're trying this. We're going to collect data. We're workshopping this. Yes, we did this before, and it was unsatisfactory, but we're going to do it differently this time. We promise. Yeah. And to your point earlier, there were some methods that were very bad. The naked parades previously, just, hey, look, if you're a woman, you got to strip down naked. You got to walk in front of this panel of male physicians, and they're going to inspect your genitalia as you walk by to make sure you're a chick.
Yikes.
Yeah, again, sports science community, medical community, has done some things in the past that don't make sense. So I'm not sure this policy, it's not worse than that, but I also don't know that it's the right policy. My second concern is like resource allocation. Like, these tests on average run $100, $150 US. You could argue the money's better spent on fighting doping, increasing access to sport for participation, things or like coach abuse, that sort of stuff, mental health. Like, there's a bunch of places you could spend this money. So kind of like an opportunity cost consideration. And then there's like an ethical consideration as well about outing athletes with DSD. Like, why do we know anything about Caster Semenya's genotype, and testosterone levels? It's like, sure, we shouldn't know that. Anyway, no easy answers here. No, and so when people say it's very simple, just do this, I'm like, I don't think you've thought deeply about this. Maybe ask ChatGPT for some thoughts here. All right, a couple questions left here, or a couple topics left. The surprising role of body weight and mortality. So we've been told for a long time that being overweight is a significant risk factor for early death. But a new large-scale study out of Denmark is challenging this long-held belief, suggesting that being too thin might actually be deadlier than being overweight. That's the headline. All right. Researchers used health data to examine the relationship between BMI and mortality in about 85,000 individuals. This population was about 81% female, and the median age at baseline was 66 years old. During the follow-up, 8% of the subjects, or about 7,555 individuals, died. And the underweight category, so those with a BMI less than 18.5, were almost 3 times more likely to have died than individuals with the reference range BMI. And that reference range was 22.5 to 25 for a BMI. Those with a BMI of 40 or above had about a 2 times increased risk of death compared to that reference population. So overall, this is like a U-shaped curve when plotting BMI against mortality, meaning those with the lowest and highest BMIs were at the highest risk of death. So the question to you, Dr. Baraki, is it really true that being too thin, having an underweight BMI is actually more risky than carrying too much body fat?
Yeah, this is not new. It's unclear to me how this is groundbreaking here. I think that if you speak with anyone who sees patients, in general, my level of concern over somebody whose BMI is less than 18 is always greater than that of somebody whose BMI is 40. I see lots of both categories, and it's something that I don't even consciously think through anymore. It's like I walk in the room and I see the person whose BMI is 18 or less. And even if I didn't know their BMI, I'm like immediately much more concerned that this person is going to have a bad outcome from whatever I might be seeing them for or outside of that context. Whereas people with a BMI of 40, 45, 50, they might be ill in their own ways or maybe don't yet have any diagnosed medical conditions or complications. And I don't feel great about their general health status and prognosis, but it still intuitively is oftentimes not as high a degree of concern as the person who is, what we'll call cachectic or super, super, super thin, skin and bones, wasted away. And I think that's the point of this, is that it is most likely at these extremes, not the BMI itself, but rather how they got there and why they got there, right? And so the reasons why somebody gets to a BMI of 16 are often more ominous, dangerous, life-threatening compared with the reasons and mechanisms that a person might get their BMI up to 35 or to 40 or to 45. Patients with advanced cancer, tuberculosis, chronic inflammatory diseases, wasting syndromes, HIV, AIDS, heart failure, chronic kidney disease, all the kinds of things that I see on a day-to-day basis in their most advanced stages lead to this chronic wasting syndrome. There's a lot of oftentimes chronic inflammation going on that can lead to appetite suppression. These patients have no interest or desire to eat. And in a tiny fraction of people who are this thin, they might have eating disorders, anorexia, which is actually one of the most dangerous, highest risk, highest mortality psychiatric conditions in existence is anorexia nervosa, as an example. Not to say that that's the most common reason why I might see somebody with a BMI in that range, but that's kind of like on the differential, so to speak, for a BMI that low. So it's much like many other conditions where we've talked about their relationships and how we interpret them. It matters to some extent how you got there, rather than the finding itself. We see similar findings, for example, when you stratify people's blood creatinine levels, their blood levels of how their kidneys are functioning. A lot of people fixate on very, very high creatinine levels as an indicator that your kidneys are not working very well. Maybe you have advanced chronic kidney disease. Maybe you have end-stage kidney disease and you need dialysis. Those are all very, dangerous conditions and high risk of death associated with those. Even if you get put on dialysis, your prognosis is not like miraculously better. It's still a concerning condition. Fewer people recognize the risk, health risks and mortality risk associated with very, very low creatinine levels. So a creatinine level of 0.1, for example, gets my attention of like, this person has almost no muscle mass as indicated by this blood creatinine level. And I'm generally more concerned that they have a higher risk here. Now, what's the solution? Is the solution to give them creatinine to make the creatinine higher? Or to, yeah. Right? Just like, these other patients who have a very low BMI, is the solution just to like force feed them to get their BMI up? That will probably not return their risk of death back to baseline, but rather it is more likely to be related to whatever underlying condition they have. So treating their tuberculosis or their cancer or their AIDS is more likely to benefit their risk of death, in the same way that the person with a very low blood creatinine level, making the creatinine look pretty isn't going to be what helps them, but rather improving their, level of lean body mass is more likely to help them, to the extent that that's realistic or possible for the person.
Yeah, you don't need to buff the chart, but I look at this a similar way that like in the long term, right? Having too low of a BMI is not really a concern, because that's not a long-term problem. It's a short-term problem, because the mortality does increase so rapidly, mainly due to, as you said, the process by which people got there, right? Yeah. It's mostly some sort of underlying condition that has moved a person from a, quote, normal BMI or even overweight or obese BMI into this underweight category. So that short-term change, yes, is very, very scary. It gets my attention. Compared to somebody who's had an elevated BMI for a long period of time, that's more of a chronic risk of exposure to excess body fat. And so, yeah, I don't think that's like I don't think it's likely to improve somebody's lifespan having too much body fat. But in the short term, yes, somebody moving down into that underweight category is very, very concerning, mostly due to the underlying process that got them there. Yeah, I don't think that having like too much body fat is now suddenly like a protective factor. It's more just an association that you see because you're not picking up how people got to these various endpoints.
Yeah, totally. Yeah, I would hesitate to make a ton out of this because a lot of folks maybe whose BMI is elevated because they legitimately are carrying a bit of excess body fat, they might, look at this and say, oh, well, I'm in
good.
the optimal range. Meanwhile, my waist measurement is, 40 inches or something like that. And there's actually room for improvement on that.
But I got all this muscle mass, dude. Come on.
Yeah, probably not.
Yeah. Okay. 2 questions, 2 topics left. One is about the impact of ultra-processed foods. We're back to this yet again. The FDA and USDA are making headlines with a request for information for a federally recognized definition for ultra-processed foods. On September 9th, the MAHA Commission released the Make Our Children Healthy Again strategy report, which outlines a broad set of proposed updates to federal nutrition and food safety policy. One of these policies to come up with a definition for ultra-processed foods. Now, to date, most studies, most researchers, most public health organizations use the NOVA food classification system. It's a name. It's not an acronym. And this separates food into 4 different groups. Group 1 is unprocessed or minimally processed foods like fruit, vegetables, eggs, meat, milk, water, etc. Whereas Group 4, these are termed ultra-processed foods, the ones that use many ingredients, including food additives, ingredients rarely used in home food preparation, and industrialized processing to improve palatability, so how the food tastes, and shelf life for the food. So cereals and a number of other sweets, desserts, etc. would all classify as ultra-processed foods, although you would also lump in whey protein powder in there or some versions of Greek yogurt, for example. So the question to you, Dr. Baraki, is coming up with a federally recognized definition for ultra-processed foods important? And if so, why?
Yes.
Okay, cool. No, moving on. Yeah.
I think it's super important because, we've talked about this a ton before as it relates to our options for addressing, the general prevalence and increasing rates of obesity in the population, both ranging among children all the way through adulthood. That we have this interaction between people, all the things that make them individual, including their genetics and their surrounding environment, and those are fundamentally our 2 levers that we can work on. And at the level of the person, we can, work on behavior change and lifestyle habits. And then we can also use, individual targeted medical treatments, be it GLP-1 agonists, other anti-obesity medicines, metabolic bariatric surgery, et cetera, to try to address things at the level of the individual. But they are still living in an environment. And that environment is increasingly toxic, shall we say, as it relates to, promoting or setting the person up for behaviors that are more likely to lead to the development of obesity and its complications. And so in an ideal situation, we would be working on both levers. I think historically, there has been much more reluctance to work on the environment because what does that even mean? Who works on the environment? Do we expect food companies, restaurants to voluntarily make their food less palatable or less appealing to people so that they will naturally consume less? That's never going to happen. And so to the extent that we want the food industry to reform in some way, if we want food reformulation, if we want changes in the food environment, the only way that happens is from the state. And so if we're looking at government level regulation and things like that. And so obviously, any form or attempt at government-led regulation is going to be immediately steeped in legal battles because that's how we do things in the United States is tons and tons and tons of lawyering and legal battles back and forth. And so that necessitates clear, distinct definitions on which we can, attach our laws and regulations and things like that if we're going to go down that road. And so absent a definition, to the extent that you want to modify anything about the food environment with respect to these quote unquote ultra processed foods, having a very clear, distinct definition is going to be absolutely essential. That's going to be a lot harder to do than it might initially seem. A lot of people might just take like I know it when I see it type definition, but that's not good enough to survive the legal battles that are going to happen. So it needs to be something that is very clearly and distinctly defined. And I don't think it's going to be a perfect fit. I think there are going to be gaps. There are going to be things missed. There's going to be what we'll call false positives and false negatives very likely in these types of definitions. And there's very likely to be unintended consequences. So this is going to be a messy process. It's going to take a long time if it even happens at all. I also have my share of questions or skepticism about the kind of overall interest of this administration in carrying this through. I think that you described this, particular commission that has its own thoughts and agenda, which oftentimes are not entirely based on evidence, but a lot of times based on a lot of deeply held beliefs and convictions that may not entirely be supported. And then that is situated within a broader administrative context of not being terribly in favor of aggressive regulation. And so how that ends up playing out, I struggle to be super optimistic that we're going to like overhaul the nation's nutrition, food system, children's health and obesity trajectory during this administration. But, I'm open to seeing what happens, starting with needing a definition and then going from there to see like what steps are realistic or feasible from a governmental standpoint.
Yeah, I think, the way I view having this definition, how it would work is that it would look, if you by this criteria are producing an ultra processed food and putting it on the market, that maybe there's either some sort of tax associated with that or some sort of, you're incentivized to not do that. Right. If the idea is like we reduce intake of ultra processed foods will improve the health of the community. Fine hypothesis. But then you have to come up with, all right, well, what is the definition of an ultra processed food? And so now you're like, is it just foods with added sugar? Or is it foods with added sugar, added sodium, added fats? Or is it all of those things plus some sort of manipulation of the mouthfeel of the food? Right? You could like go down. You could come up with, as little as, one criteria all the way to like hundreds of criteria. And then like food manufacturers are then going to like weave around that ultimately to probably increase profits under the current model. So yeah, I think it's important, but it's going to be challenging to come up with a satisfactory definition, especially now that Kevin Hall is no longer on the case.
Yes.
That's going to be a problem. So we'll see what happens here. I did have this idea. All right, so you're familiar in healthcare with the idea of a capitation model, right? So if you're not familiar with this, instead of a fee-for-service model, most of healthcare uses that. There's this alternative model where, look, the provider, the physician in this particular case, would receive like some sort of set payment. And effectively, if there are issues with them providing high-quality care, right, they end up using way more resources than would be predicted or whatever. Some of that can get docked or deducted or whatever. What if that was the case for food manufacturers? The government identified, look, you're the top 20 food manufacturers for the food supply in the United States. We're going to pay you X every year, right? Provided you do these things for you improve the quality of the food and whatever, but you can't raise prices. So food insecurity potentially goes up and, whatever. And you got to make these things tasty so people actually eat it, like whatever. And until you start doing weird stuff, at that point, we're going to start fining you. Is that any? I don't think it would be very popular. I don't think anyone would go for it. But I thought, like, what an interesting model that would be, because then they're not incentivized to just sell more product. They're incentivized to put the best product on the market and have people actually consume it so they don't get dinged throughout the year. I don't know. What do you think about that? Is that crazy? Am I?
Yeah, dude, that's crazy.
Fair enough.
I think there's some fundamental kind of American socio-political understanding here that's kind of leading to some deep down discomfort at that idea. I think the number of unintended consequences from a strategy like that would be massive, and it might be both unintended, but might be like very predictable consequences from people with more economics expertise. But yeah, that sounds crazy.
All right, capitation model, Barbell Medicine template, when? Yeah, all right. Last topic we're talking about The Rock. There's been some recent controversy surrounding Dwayne "The Rock" Johnson's weight loss, with speculation flying around on social media and in the news. The conversation was sparked after he appeared at recent film festivals with a noticeably leaner physique for his upcoming role as MMA fighter Mark Kerr in the movie The Smashing Machine. Great title. Cool, by the way. Yeah. Johnson has since addressed the weight loss, explaining that it was a deliberate transformation for his role in The Smashing Machine and a new role where he'll play a whimsical and eccentric 70-something-year-old. He attributes the change to a new diet and more endurance-focused workout regimen to embody the character of Mark Kerr. He says he lost about 60 pounds. So the question to you, Dr. Baraki, how did he do it? Did he just, stop using the pharmaceutical enhancements that are likely resulting in his previous physique, although he has denied that he's taken anything since as an adult. He said, in my previous years, sure, but no longer. Was he taking Wegovy or Ozempic or Zepbound, or just training alone, just endurance stuff?
Obviously, neither of us really know. I think that this harkens back to some extreme examples of like movie transformations. Of course, the one that comes to mind most immediately is Christian Bale's transformation from when he was, on one hand, like in The Machinist, and he weighed like 120 pounds and lived on like a can of tuna and an apple a day. And that must have been absolutely horrendous and miserable at the time. All the way up to the other end of the spectrum when he's played roles where he actually carried like a lot of body fat for for various things. I think one memorable one was when he played Dick Cheney in Vice. That was also an excellent movie, as well as a couple others. And so I'm thinking about like if you or I were in that scenario, if we happened to be actors and we needed to be able to manipulate our body composition a ton, and you had access to really any of these things. For The Rock's prior roles where he needed to be a behemoth of a man and needed to be lean and muscular and things like that, pretty tough to argue that there were no anabolics involved in that process, which I don't particularly care about as it relates to somebody doing acting for movies. That's a different world than in competitive sports where things are tested, for example, and things like that, as setting aside the legality or illegality of these things. The more interesting idea is with respect to the GLP-1 aspect, because I suspect that Christian Bale was living in absolute misery that whole time when he was preparing for the machinist role. Just, you must be ravenously hungry. And that's something that can just erase that. It can markedly reduce the suffering associated with something like that. And so, on a very individual kind of physiologic level, it depends on his response to energy deficits and how much the hunger and the appetite end up being an issue. Like if I were in his shoes and you had the means and the resources and you needed to get down to a certain weight or a certain degree of leanness, you could do it without these meds and be potentially miserable and hungry all the time, which for me would be particularly tough because I have a very difficult time falling asleep if I have an inkling of hunger, much less like ravenously hungry. So yeah, I would totally do it. Use these tools at my disposal to achieve the necessary target physique and body composition for the movie role. And training certainly is going to play a role, but I don't think that that's particularly difficult for someone like him who's been training for his whole life at this point. And then the rest is just bonus. What do you think?
Yeah. I mean, so the idea that this was just a training alone, endurance focused workouts, I'm like, nah, because you think of the size of Dwayne Johnson, you saw the size of The Rock compared to like an IFBB pro, bodybuilder or whatever, and like how they get in shape for a show. And it's like, well, look, if you switch to doing a lot more cardio, less lifting, would you lose some muscle mass during that process as you lose weight? Sure, but not 60 pounds, my friend. So that seems unlikely. Potentially contributory, sure, from like an energy expenditure standpoint, but definitely not the main factor here. And similarly, when people are like, oh, he just came off the anabolics, off the steroids. And I'm like, you're telling me that this man with an incredibly busy schedule is somehow immune to all of the side effects of coming off of all anabolics, the insomnia, the fatigue, lots of muscle mass loss, increase in body fat, potential psychiatric conditions that are associated with that lull when you come off before your body hopefully kicks back into gear. Seems highly unlikely. The doses might have gone down, the regimen might have changed, but the idea that I just stopped and this is what happens, particularly in short order, unlikely. I would suspect, again, given the access, I wouldn't be surprised if he was on a particular dose of a GLP-1 receptor agonist or combination medication just to deal with the hunger and make things more palatable, to use another terrible pun, mainly because it's like, why do you need to suffer?
Yeah. Nobody cares.
Yeah. And that's something I've been saying recently when asked. I'm like, I don't necessarily care if people want to use these things recreationally to lose weight. Like, you don't get a gold star for like, it being a worse experience for you.
Agreed.
But the last thing, just quickly, are there any impacts on society from this sort of thing? I mean, you got to think he had particular roles that he was selected for due to his size. I think of like, all of the action, smash him up, Fast and Furious, whatever, the Rundown, so on and so forth. It's like, yeah, you're supposed to be this big hulking, G.I. Joe type character. And so you have a particular body you need to fit into, and that has an impact on society and what they expect. But now you're going to be considered for more roles as a a lighter individual. Batista, same thing.
Yes, he's another one that came to mind in the same way.
Yeah, and it's like, I actually don't know, because you've almost been typecast as a particular type of actor already. I mean, I don't know anything about, casting folks otherwise, but I'm just thinking, I'm like, imagine there's it's like a drama, or a love, a rom-com, and The Rock gets cast as like a, nerdy kind of empath or something like that. Seems highly unlikely to me, but yeah, I don't know. Does this change the way people view this maybe hyper muscularity sort of thing, in your opinion?
Yeah, hard to say whether this reflects any sort of more generalized like social trend, but I remember when we were getting into the lifting world. Do you remember what was his name? Justin Lasic's website, 70s Big?
70s Big, yeah.
That was a very entertaining resource back then, but there is this kind of more, at this point, it does feel a little bit more like historic glorification. And this is outside of like the highest level competitive bodybuilding scene, because still at the highest levels of competitive bodybuilding, you see the freakiest physiques that are looking more and more alien each year that goes on, it seems. But if that's what is incentivized, then so be it. But that's not necessarily what's reflected in broader society. But this is interesting that things are kind of evolving in this direction. It also feels like there might be some evolution in that, just in the training world at this point, outside of people trying to get as huge as possible. Again, outside of competitive bodybuilding, that there's a lot more people. I don't know. Maybe this is just within our bubble, but leaning into conditioning a little bit more and not necessarily aiming for those kind of maximalist physiques, or really on either end of the spectrum. So I hesitate to speculate on whether this is a general, more a broad societal trend, but I do think that people at that level of social popularity, like Bautista, like The Rock, things like that, if more of them continue to do that, then that's the kind of thing that does percolate more into society and pop culture and things like that, and kind of define the trends and what things are. What sorts of physiques and things like that people are seeking with their training and activity, where maybe at one point in the past people were more like, I remember hearing a lot about the Brad Pitt Fight Club look that people were looking for, which is like quite skinny in that look, versus like massive, like The Rock in many of his prior roles, or Bautista, and now kind of maybe a little healthier in between, potentially. I don't know.
Yeah. Did you ever watch what was it, Beer Fest? Where so. Gunther is I mean, the dude's one of the biggest bodybuilders ever. Mm-hmm. Like, I think his off-season weight like pushed into the low 300s or whatever, and he's still just huge. But he's like cast there to be like this big German drinking machine, and I'm like, cool. I want to be that big at some point. I don't know. Yeah, I think you're right. Like, I don't know. It wouldn't surprise me if The Rock ends up doing like a High Rocks just to like lean into that.
Sure. Yeah, that'd be cool.
And did you have a favorite wrestler, like WWE or at that point WWF wrestler growing up?
Oh, I was kid for sure.
That's fine. Maybe we'll bleep that out so people don't know. Ric Flair is obviously my guy.
Sure. Yeah.
Can we get a woo to sign off? You got a woo for me?
Woo!
That's right. All right. Well, that is a wrap here on the Barbell Medicine Podcast, where we bring modern medicine to strength and conditioning to modern medicine. Special shout out to Dr. Austin Baraki for joining us on the 4th episode of The Rundown, where we bring you the latest headlines in medicine, fitness, nutrition, and sports. I'm Dr. Jordan Feigenbaum. We'll catch you next week and every week right here on the Barbell Medicine Podcast.